Welcome to The Explainer, everyone. I'm your host and clinical nurse educator, and today we're diving deep into the critical care side of nursing. We're going to put a laser focus on two of the absolute most tested and honestly clinically vital electrolytes you'll encounter: calcium and potassium. So whether you're gearing up for your nursing cadre DPE, tackling the NCLEX, or just want to really sharpen up those acute care skills, you're in the right place. This is the high-yield review you need.
I want you to think about this for a second. What actually happens when a slight, almost microscopic shift in a patient's blood chemistry triggers a sudden, life-threatening cardiac emergency? Because as nurses, we're right there at the bedside. We are literally the first line of defense. A shift of just a few milliequivalents, that can literally be the difference between a perfectly stable patient and one in full-blown cardiac arrest. So let's get into this and make sure you're fully equipped to catch those tiny shifts long before things turn fatal.
All right, here is our clinical roadmap for today. We're going to start with foundational definitions, then right into the highs and lows of calcium, followed by the highs and lows of potassium. After that, we'll hit the essential nursing management, and finally wrap it all up with a high-yield clinical review. Let's get to it.
Section 1, Foundational Definitions. Let's set our baseline.
You really want to notice just how tightly the body regulates these numbers. Normal serum calcium sits right between 8.5 and 10.5 milligrams per deciliter. Now, about half of this is bound to plasma proteins like albumin, but the rest is free. It's biologically active, and it's what drives bone structure and, absolutely crucially, physical muscle contraction. Normal serum potassium, on the other hand, has a remarkably narrow window. We're talking just 3.5 to 5.0 milliequivalents per liter. It's the major intracellular cation. If calcium is the physical muscle contraction, think of potassium as the electrical conduction that actually tells that muscle to fire, especially in the heart.
Section 2, Calcium. Let's look at the highs and lows. Breaking down the root causes here, we define hypercalcemia as a serum level jumping greater than 10.5. Take note of how malignancies, specifically things like kidney, lung, ovarian, and parathyroid cancers, heavily drive up calcium levels. Why? Because those cancer cells can basically dump massive amounts of calcium straight into the blood. On the flip side, we have hypocalcemia, which is any level dipping below 8.5. This drop can be caused by hypoparathyroidism, a severe vitamin D deficiency, or even from giving massive blood transfusions.
Now, when your patient has too much calcium, hypercalcemia, I want you to think of one word: sluggish. Your patient is going to present with muscle flaccidity, weakness, profound lethargy, and some really dangerous heart blocks. But contrast that with hypocalcium. When calcium is low, the nervous system essentially goes into overdrive. It becomes hyperexcitable. Your patient gets twitchy. You'll start seeing numbness and tingling around the mouth, hyperactive reflexes, muscle tetany, and highly dangerous cardiac arrhythmias. The key takeaway: low calcium equals hyperexcitable tissue. Section 3, Potassium highs and lows. This is arguably the most critical electrolyte. Looking at these causes side by side, hyperkalemia is when levels creep over 5.0. Since the kidneys are responsible for excreting potassium, acute or chronic renal failure is a massive glowing red flag for hyperkalemia. Medications like ACE inhibitors and potassium-sparing diuretics also trap it right there in the body. Then we have hypokalemia, which is below 3.5. This is usually driven by profound fluid loss. Think GI suctioning, severe vomiting, diarrhea, or potassium-wasting loop diuretics like furosemide. Oh, and here's a pretty wild clinical fact straight from the literature. Eating excessive amounts of licorice can actually induce hypokalemia. It contains a mineral corticoid compound that just drains it out of you. Crazy, right? When we contrast the clinical signs of these potassium extremes, something really fascinating emerges. Whether your patient is severely hyperkalemic or severely hypokalemic, both of these extremes ultimately lead to the exact same scary endpoint: severe muscle weakness, flaccid paralysis, and life-threatening cardiac dysrhythmias. Hyperkalemia might kick off with GI cramps and diarrhea before moving into paralysis, whereas hypokalemia often shows up first as a paralytic ileus, with decreased bowel sounds and orthostatic hypotension. But listen, in both scenarios, the myocardium, the heart muscle itself, is in immense danger. Section 4, Essential Nursing Management and Evidence-Based Protocols. Because both calcium and potassium directly govern how the heart beats, continuous cardiac monitoring is absolutely non-negotiable. It's mandatory. Right here, you can see the exact precordial lead placements for a 12-lead ECG. It starts from V1 at the fourth intercostal space on the right sternal border and sweeps all the way across the chest to V6. You have got to know these landmarks so you can accurately capture the electrical waveforms we're about to talk about. Now, this comparison right here, this is exactly how you're going to be tested on your board exams, and it's exactly what you'll need for real-world emergency recognition. For hyperkalemia, you need to memorize this progression: tall, tented, peaked T waves, followed by a widened QRS complex, and then flattened or even totally absent P waves. For hypokalemia, it's different. The T waves flatten out, the ST segment gets depressed, and you'll see the classic elevated U wave. These visual ECG markers are literally your earliest warning signs that a cardiac collapse is impending. Which brings us to this crucial number, 7.0 milliequivalents per liter. If you see a patient's potassium level cross 7.0, you are officially in the red zone. The clinical literature warns us that levels above 7.0 are highly, highly likely to trigger sudden cardiac arrest. You do not wait around here. This demands immediate, vigorous emergency treatment. So, what exactly does that emergency treatment look like? Here are your step-by-step pharmacological interventions for severe hyperkalemia. First things first, protect the heart. You're going to administer 10% calcium gluconate IV rapidly to decrease that myocardial irritability. Next, we need to force that potassium back inside the cells, so we give regular insulin along with 10 to 50% IV glucose. The glucose is just there to prevent hypoglycemia. Finally, we actually have to get the potassium out of the body, right? We do that using sodium polystyrene sulfonate, which you probably know better as Electrolyte, or by getting the patient ready for emergency hemodialysis. Conversely, for hypokalemia, your management shifts entirely to safe replacement. If you're administering IV potassium chloride, you must, absolutely must, use an electronic infusion device. Never, ever push potassium IV. It is lethal. And here is a massive clinical alert for you. Hypokalemia strongly enhances the effect of digitalis preparations. So if your patient is on digoxin and their potassium drops, they are at an extraordinarily high risk for digitalis toxicity. You've also got to educate your patient on eating a high potassium diet. Think bananas, apricots, baked potatoes, all the good stuff. For calcium imbalances, the interventions are pretty straightforward, but they're incredibly critical. For hypercalcemia, your main goal is to dilute and excrete. You'll administer normal saline IV, give loop diuretics, and really encourage the patient to get up and move around to keep that calcium locked in their bones. For hypocalcemia, remember how hyperexcitable the nervous system gets? Because of that, you have to institute immediate seizure precautions to keep your patient safe, and then carefully administer IV calcium. Section 5. High-yield clinical review. Let's bring it all together. I want to read this essential clinical quote directly from the source text for you, because it really is that important. Quote, "A slight decrease in potassium can have a profound consequence. Hypokalemia enhances the effect of digitalis preparations, making the patient prone to potentially fatal cardiac dysrhythmias." End quote. I want you to permanently cement this relationship between low potassium, digitalis, and fatal arrhythmias in your mind. It's a classic clinical trap, and recognizing it early absolutely saves lives. So, to summarize our core strategy for today, master those specific ECG changes. Memorize the tall, tented T waves of hyperkalemia versus the flat Ts and U waves of hypokalemia. Nail down those strict normal ranges, especially that incredibly narrow 3.5 to 5.0 for potassium. And always, always anticipate a cardiac emergency when these numbers start to drift. Never just look at a lab value in isolation. Look at it as a real-time predictor of your patient's cardiac performance. Which leaves us with this final thought. Imagine you're at the bedside. Your patient is on a loop diuretic and digoxin, and suddenly their potassium drops. Are you prepared to catch that U wave on the monitor before their heart stops? Keep studying your ECGs, keep those lab values fresh in your mind, and stay vigilant out there. Thanks so much for learning with me today on this explainer, and I will see you in the next one.